the roll.
Sure. I'll start with you, Commissioner Chow,
Present.
Commissioner Green,
Present.
and Commissioner Christian.
Present.
All right. Thank you very much.
Why don't you call the next item since this works better on the Zoom here.
Yes, sir. I will read the land acknowledgement before we do that.
Oh, yes.
Yes. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Thank you. Item 2 is the approval of the August 24th, 2021 Zsfg minutes. And as I noted before the meeting began, Commissioner Chow requested a slight change to page 2. I will read that out for the folks in the public and for the record. Page 2, paragraph 4, under Equity A3 presentation. I'll read the whole sentence and let you all know what's new. Commissioner Chow encouraged Zsfg to look deep in its data to best understand where there may be health inequities in discrete services. And then he asked to add this, by disaggregating data, for example, by race, gender, or language when appropriate.
Okay, so commissioners, you have before you the minutes, including my little revision, just to make it clearer what we had talked about last month. And a motion for its acceptance is in order.
So moved.
And a second.
I second it.
Good. Let's call the roll.
Yes, I'll note nobody on the public comment line, everyone's staff. Commissioner Christian.
Yes.
And nice to see you. And Commissioner Green.
Yes.
And Commissioner Chow.
Yes.
Great. The item passes. Item 3 is the Regulatory Affairs Report.
Good afternoon, Commissioners. Can you hear me okay?
Yes, thank you.
So for this month's Regulatory Affairs Report, we have one upcoming survey next week, at the CARF survey of the office, the opioid treatment outpatient program. So that's a 3-day survey, and that program's accredited by the CARF organization as a rehabilitation program. Regulatory Affairs team have been doing a lot of preparation with Hasia and the leadership in that area to be ready for the survey. We have some other pending surveys, but we really are not sure when they're going to happen. So the Laboratory Joint Commission survey and some 4A surveys and our dialysis recertification. Completed surveys on the report, you'll see a DEA visit to OTOP and the CDPH Radiology Health Branch and a mammography survey, both very successful surveys. No deficiencies from the DEA and only 2 minor deficiencies for the radiology branch survey. What doesn't appear on the report is we also had a visit from CDPH for 4A last week on their COVID mitigation survey. They toured the unit, they interviewed staff, and they reviewed our documentation around the plans and how we are implementing ways to keep our residents safe on 4A. And the survey ended with no anticipated deficiencies. You'll see we still have a long list of outstanding self-reported incidents that the state are investigating, and we have a total of 9 of those that have been referred to the Joint Commission for us to follow up separately with them. They will not be investigated by the state. There are 5 new facility reported incidents, an elopement, a privacy breach with unauthorized information being given by a text, a fall with fracture, a HAPI, and a patient-to-patient sexual assault. And then we also have some plan of correction monitoring data at the end of the report. And this is from our Joint Commission surveys earlier this year. So we really wanted to showcase the great work that's being done If we look at, first of all, the Joint Commission TBI certification survey, you can see that compliance hasn't reached our desired 90% there, but we really are doing a deeper dive and not just looking at the TBI patients, but anyone that's receiving neuro-op. So I do actually want to acknowledge that and really highlight how that department is going above and beyond to make sure that this performance improvement is occurring for anyone having these kinds of observations and not just the TBI patients. And then, as you can see from the Joint Commission main survey, we highlighted, first of all, those condition level findings. And as you can see, we're fully compliant in all of those areas. We do want to, we are choosing to continue to monitor instrumentation outside of the OR because we really want to be sure that that change, that additional education is ongoing. And we also recognize that there's absolutely a possibility that there could be a handful of outlying instruments that didn't quite make it into the initial sweep. So we want to continue to monitor just to make sure that we haven't missed anything, and we'll continue to do that just for a little while longer. I'm happy to take any questions or comments you have on the regulatory affairs report.
Is there any public on the line yet, Mark? Or?
No, sir, there's no one on the line.
Oh, okay. Then we'll go ahead with either comments from the members or questions and comments from our commissioners.
I do not see hands, commissioners, from anyone, from staff or from other commissioners.
Okay, so I had a comment which I just thought of now, and thank you for that plan of correction monitoring data. I think that is terrific. A very nice summary of where we were with the items that were open, and the fact that many of them are now closing, and that sort of closes the loop on our reporting here. I'm wondering, and you're acquainted, we have so many FRIs now, and many of them are pending, whether we would consider that at Laguna, which has always had many, we actually did or your staff here, the quality staff, actually was able to actually put that into a chart, a format with bars showing what months and how many have really been closed, how many haven't, and how many had findings and how many have not. And that's actually in these years, these several years that they have done that, has been really helpful to understand the status of the FRIs. I think some of our commissioners, I know Commissioner Green has seen that, and I'm wondering if she would think that that would be helpful to understand this volume that we have. I think you're on mute. Yeah.
Yeah, I mean, first of all, this it's so pleasing to know you've done so well with these surveys. Congratulations, to everyone. Yeah, I mean, it's very helpful. I think before we ended up with this giant backlog, it was, there was a rhythm to it, and now we're just looking, going, really, 2019? So it does help to have that flow chart in its own way, because at least it helps us understand, what's been addressed. And I mean, these are obviously external forces we have no control over, but it is nice to know if the wheels are starting to turn or what's going on.
I think that's great feedback. Thank you, commissioners. I think historically our turnover have been much quicker and our volumes have been lower than Laguna Honda, but this is definitely a suggestion that we can collaborate, learn from, and I can work with our regulatory affairs team to begin to present this data in a more graphic manner for the prior years, if that would be helpful.
Okay, yes, thank you. Thank you so much. I know it's a little extra work, but it really will, I think, allow us to follow these a lot more appropriately, I would say, and with a little more meaning. Otherwise, it just looks like we've just got a ton of them and they're just increasing. And it is so nice to know some of them have already been resolved. Most of them were resolved, as you know, to the satisfaction of the institution, and then some had corrective actions, which then get noted as you have noted already. So thank you very much for your consideration on that. Are there any other comments? This, of course, is really a very complex, and I just, again, want to reemphasize, as Commissioner Green has, that I think this reporting on all the various surveys we have, and just the simple pages, the used to be one page, front and back, but now it's 2 because of the FRIs, has really helped those of us who have been charged with following Laguna, well, in this case, General, to understand all the work that you're doing. And I'm also glad to say Laguna has followed a similar pattern, so that now we are also feeling quite comfortable in understanding all the surveys there. So thank you, Adrian, and for your group. And I know, you know, everybody working to try to see that there is some harmony between the two organizations in the reporting.
Thank you.
Okay, shall we go on to our next item, please?
Sure. Item 4 is the quality measures scorecard. Leslie will be presenting.
All right. Are you able to see my screen?
Yes, looks great.
Great. All right. So today I'm going to talk to you about my favorite topic, quality data reporting. Okay. So this grid shows the Zsfg kind of universe of quality regulatory reporting requirements. There are 3 different colors on this grid, and they mean different things. So the first is purple, and the Joint Commission is in purple, and that designates information that we report for purposes of accreditation. So we have certain reporting requirements to the Joint Commission around performance improvement measures to maintain our accreditation status. The next is orange. Orange is pay for reporting. So we have 3 main CMS, or Centers for Medicare and Medicaid and Medicare Services programs, that we report to, and we receive payment based on fulfilling reporting requirements, not based on how we perform, but by reporting data, we receive credit and reimbursement based on reporting. And then the third category is the pay for performance program, and that's in teal. Those we receive reimbursement based on how well we do. So the largest pay for performance program we have is the Quality Incentive Pool, or QIP program. However, we participate in a few others, the provider preventable condition reporting, and then 3 programs that I'm going to go into more detail later: value-based purchasing, hospital-acquired conditions program, and readmission reduction. And those are really fed through one of our pay-for-reporting programs. So we send data to CMS for our pay-for-reporting program, but then that data is also used for pay-for-performance programs, and that also feeds our star rating information that I think I presented maybe in April of this year. So first, I'm going to focus on what we call our core measures. And core measures are reported through 4 main programs. One is the Joint Commission, but the Joint Commission really follows in alignment with the measures required by CMS. So it's mostly most of the same measures. So we participate in the CMS Inpatient Quality Reporting Program, the CMS Outpatient Quality Reporting Program, and the CMS Inpatient Psychiatric Facility Quality Reporting Program. These are all pay-for-reporting programs, and there are 3 types of measures really within these programs. One are chart abstracted measures. So those are measures where medical record abstractors or analysts go into the medical record and answer a series of questions if documentation exists. It doesn't specify where the documentation exists, but we're looking for the documentation within the medical record. The next piece is electronic clinical quality measures. So these are metrics actually built into the Epic system and that have no manual abstraction. So it does depend on where specifically the data is and where things are charted in the record. And then the ECQM develops a performance report for us. And there's no way for the abstractor to go, actually, they charted it over here and not over here, so they should get credit. It doesn't allow for those type of allowances. And the future is trending more towards electronic clinical quality measures. And the last is Medicare Claims. And this is another pretty popular type of measure. Medicare calculates metrics for us based on claims that are submitted as they're the payer. And then a subset of these metrics are also reported to the Joint Commission. So I'm going to go through now a selection of some of our core measures. So these are our perinatal core measures. So you can see our performance here. This quarter, we actually took a look and we recognized that we're seeing actually a lot of variability in these metrics. And what really led us to that is seeing that C-section rate of about 8%. Compared to the past 3 quarters, this is a lot lower. And based on speaking to our providers, we believe that this may be artificially low. So because of the variation we're seeing in this metric, we've decided that our sample may not be representative. We're not looking at all cases. We are only looking at about maybe 30% of cases. And so moving forward, starting in Q3 2021, we're going to look at closer to 50% of cases, hopefully that our sampled rate will better reflect the true rate. So those are looking at our different metrics there in terms of meeting all our goals in the perinatal measures. And I just wanted to share, we have here our Vizient median. So I got a great question from Commissioner Green about what our Vizient median is. And so really, Vizient includes academic medical centers, pediatric facilities, community hospitals, integrated healthcare delivery networks, and non-acute care providers. So a large number of different providers. They shared that they actually encompass about 95% of academic medical centers and 50% of acute care hospitals. So we actually are able to provide benchmarks from various groupings. And so for our next report, we are going to try to do the benchmark from community hospitals. So Vizient does have a subset of community hospitals. And so we'll work to get that benchmark in here just so we can compare ourselves to the other community hospitals that may be more familiar to us. Our next measure, these are our psychiatric core measures. These are not all the measures submitted through the inpatient psychiatric program. Those are actually coming to PIPS in October, so you'll see them coming through the PIPS minutes. But these are a selected few. And so we're looking at physical restraint and seclusion use. So we actually saw marked decreases in both restraint and seclusion use this quarter. Speaking with the psychiatry team, they shared that high seclusion hours have been made part of the huddle board and is reviewed daily. They have multidisciplinary team meetings to discuss each patient in seclusion and restraint with the goal of really reducing hours. All disciplines, so looking at the doctors, occupational therapy, social work, nursing, have seclusion and restraint prevention and reduction as a priority through use of meds, patient engagement, use of individual patient coping skills plan, and immediately addressing escalating patient behaviors prior to seclusion and restraint. And so a lot of this work and these different interventions have helped us see this reduction in seclusion and restraint hours. I looked to find previously CMS had provided a national rate for seclusion and restraint. They, however, this is a prior national rate. They have stopped providing this data. I've done some searching. The closest thing I was actually able to find was VA hospitals. So I was able to find a list of VA hospitals and how they performed in seclusion and restraint. And the benchmark I found I was looking at different California VA hospitals. The San Francisco VA is very low. It's 0.05 restraint and seclusion hours per 1,000 patient hours. The highest in restraint use was actually in the VA and greater LA healthcare system at about 0.34 hours per 1,000 patient hours. And then highest in seclusion was at our VA in Northern California at 0.52. But unable to find any benchmarks from organizations that we consider like us. The next metric we have here is patients discharged on multiple antipsychotic medications with appropriate justification. And so the question was posed, what is appropriate justification? So there are 3 things that actually constitute appropriate justification. One is the medical record contains documentation of a history of a minimum of 3 failed multiple trials of monotherapy. The second is the medical record contains documentation of a recommended plan to taper to monotherapy due to previous use of multiple antipsychotic medications or documentation of a cross taper in progress at the time of discharge. And the last is the medical record contains documentation of augmentation of clozapine. And so that is actually what constitutes appropriate justification. And when I looked at the benchmark for this, looking at for Q3 2020 within Vizient, the benchmark was 78%. Right? And so these are electronic clinical quality measures. These are reported once per year. So I shared these at my last update. It didn't change. So we were able to put a lot of effort actually into validating the stroke 2, 5, and 6 metrics this past year. However, we still need to do some validation on the EVTEs. So we're actually working currently with the orders team around validating these VTE ECQMs, because Epic provides us the value, but we really need to go through and look at the different components to make sure that we're being measured accurately, because this data is going to be publicly reported. All right, now I'm going to switch from the pay for reporting programs into the pay for performance programs. These are programs that we get reimbursed based on how well we do. 3 main CMS programs. One is value-based purchasing, which looks at 4 different domains: clinical care, person and community engagement, safety, efficiency, and cost reduction. This year, we are not getting a score for value-based purchasing. Because of the pandemic and how many metrics were affected by it, CMS has decided to do a neutral payment adjustment and will not be scoring value-based purchasing. However, they have chosen to give scores on the other 2 programs: hospital-acquired conditions program, which looks at hospital-acquired conditions or safety, and then the readmissions reduction program, which looks at 30-day readmissions. So hospital-acquired conditions looks at 6 different measures. One is the PSI 90 composite, and then the others are central line-associated bloodstream infection, catheter-associated urinary tract infection, surgical site infection for hysterectomy and colon, MRSA, and CDI. 3 of these metrics, CLABSI, CAUTI, and SSI of the colon, are also reflected as part of our safety True North metric that will come. I believe that there is a True North update today on our scorecard. So CMS did decide to keep this program. However, they said, let's exclude 2020 data. Because of the pandemic, they chose to exclude calendar year 2020 data from the program. The PSI 90 data is from July 1st, 2018 to December 3rd to December 2019. However, the other data is for calendar year 2019. We are subject to a payment reduction. So this is a program where if you perform in the bottom 25%, you're immediately subject to a 1% payment reduction. And for us, that translates to $927,600. And that's an estimate of what that payment reduction is. All of these metrics are included in the CMS Star Rating. So there's a lot of overlap between the Star Ratings and this program. We performed best in MRSA bacteremia. And then consistent with the Star Ratings, we see our biggest areas for improvement in PSA 90 and colon SSI. So we really, in terms of recommendations, we recommend continuing our colon SSI improvement work. We continue to see that number reduce over time. And actually, we are going to be looking at that data in more detail for the calendar year 2019 and 2020 as part of our PIPS report, PIPS presentation in October. So breaking that down a little bit more, but when we looked at the surgery department actually presented this at PIPS in September, and looking at the fiscal year, sir, we've seen significant reductions in colon SSI, our standardized infection ratio. PSI 90, it's a little harder for us to tell. However, we instituted a review process. So any case that was coded as a PSI 90 was reviewed by our clinical documentation integrity team prior to billing, starting in about 2020. So this doesn't include any of those improvements in this data. So we do expect these metrics to start looking better as time progresses. Now, the other program I'm going to go over is the readmissions reduction program. So there are 6 metrics included here. really looking at 30-day readmissions. To note, these are Medicare patients only. So these are patients who, but it also includes seen at any facility. So this doesn't just include readmissions to Zsfg. This is a readmission to any facility within 30 days. And the readmission doesn't need to be related to the specific condition. So this also excludes 2020 data and looks at from July 1st, 2017 to December 1st, 2019. Readmissions do so. Some of this overlaps with the star rating. Zsfg actually does not do CABG, but readmissions due to chronic obstructive pulmonary disease, hip and knee replacements are included in the star rating. We are subject to a payment reduction, but it's lower with this program. It's it isn't an all or nothing. So this is about $73,000. Of note, this is the only CMS program who looks at dual eligibility. So this looks at Medicare and Medi-Cal dual eligibility and puts all the hospitals into 5 different groups based on their status and then compares within status. So we are in peer group 5, the group with the highest proportion of dual eligible. As I shared before, we're limited to Medicare patients, but includes readmission at any facility. We performed best on the pneumonia readmissions, and then we saw areas for opportunity in hip and knee replacements and heart failure readmissions. However, there weren't huge deltas between our performance and those of our peer group. All right, I just went through a lot of information, so I just want to pause now and ask what questions you have.
And there are folks on the public comment line, Commissioner Chow, may I ask to see if they would like to make any comment?
Yes, please.
Sure. Folks on the line, if you would like to make comment on this item, which is item 4, quality measure scorecard, please press *3 to raise your hand. *3. No hands, Commissioner Chow.
Okay, let me just start with the first question, which is in the 2 payment reductions, what is that a reduction from in terms of the total?
So I believe that the first, do you want the total amount, or can you specify?
Yeah, in other words, we're going to lose $900,000. What actually did we gain?
So it looks at, from my understanding, it looks at what we pay for what we pay to Medicare, and then based on our claims and the amount of money that they would pay us, and they reduce it by a certain amount based on all our claims during, I believe it starts October 1st, 2021 to September 30th, 2022, would be reduced either by 1% from the HAC program, and then I think it's 0.15% for the readmission reduction program, but that dollar amount translates into what we're seeing.
No, that's fine. No, thank you. That's what I was curious about. I thought you did say 1%. So
yes,
the other one, and this one's even smaller. Okay. Nevertheless, though, of course, we should be, doing better because some of these will hit the star ratings, right, which is sort of a public reporting. So that was my question. Commissioners, any further questions? Again, a very clear presentation, and each time we go through this, I think I might finally get it in the end, but your diagram is very helpful.
I don't see any other hands from commissioners or staff, Dr. Chow.
Okay, well, they were very clear, and we'll look for some of the
great.
Some of the details later, as you promised, and so we can go on to our next item. Thank you very much.
Sure. Thank you, Leslie. Item 5 is the True North scorecard. And Chris, I just gave you permission, so it might take a second, but that button should show up. There we go.
I see it. All right. Can everybody see my screen?
Looks great.
Perfect. I think we have Dr. Marks here with us. Wanted to chime in before we get going.
Am I unmuted, Mark?
Yes, you are.
Okie doke. So good afternoon, commissioners. Before my colleague Chris Ross reports the True North scorecard, I just wanted to let you know that after a longer than expected 1.5 year deployment to the COVID command center, I am backed as Zsfg's Chief of Performance Excellence. So in fact, this is my first JCC in a year and a half also. In my CPE role, I'll be continuing to support Zsfg's strategic planning and strategic deployment, amongst other things, and that includes the True North scorecard. So take it away, Chris.
All right. Hello, commissioners. I'm Chris Ross. I'm the Strategic Planning Manager in our Kaizen Promotion Office, and today we will give you our quarterly update on our True North scorecard. So if you all remember, we have 6 True North pillars: equity, safety, quality, care experience, developing our people, and financial stewardship. Within each of those pillars, we have a key performance indicator or a metric that we've been tracking throughout this year with a strategic driver behind it. So within our equity pillar, we have our departments driving equity KPI, and this is measuring the percentage of departments that report to our Performance Improvement and Patient Safety Committee that have an active improvement project around reducing disparities or something that is equity related. Our goal is to have half of all the departments that report through this committee have an active driver. And right now we are in the green with 57% of our departments that have reported thus far have an active driver. Within our safety pillar, we have a composite of patient safety harm events. This includes our catheter-associated urinary tract infections, or CAUTI, and this is a rate of the number of occurrences by 1,000 urinary catheter days. We are in the red with this one with a rate of 4.28 and a target of 2.26. The next metric we have within this composite is our central line associated bloodstream infections, or CLABSI. Again, we calculate this using a rate. Our goal is to be under 0.77, but we've reset these metrics with the fiscal year. So far we fortunately are off with a count of 1 and a rate of 1.31 for our CLABSI metric. Colon surgical site infections is our next one. This is another rate of infections by procedure count. We are in the green with this one with a rate of 1.21 and a target of 1.62. And then finally, we have falls with injury across our Med-Surg 4A, emergency department, and inpatient psych units. Again, this is another rate. We are looking at occurrences of falls with injuries over 1,000 midnights. In our rate, we are unfortunately off target as well. The rate of 0.98 and a target of 0.22. Within our quality pillar, we have another composite. This composite looks at access and flow throughout our entire campus. Our goal is to have 4 out of 5 of our targets, of our metrics on target. Currently, we sit at 58%, with 22 out of our 38 from January until August being on target. The first metric within this composite is our emergency department diversion rate. So this is looking at the percentage of time between 12 a.m. to 12 a.m. that our ED is on diversion. As you'll see, from January until June, we were under our goal of 40%, but in the past 2 months, we've creeped up a little bit, which has put us in the red with a year-to-date of 42.35% of time on diversion, a goal of 40%. The next metric looks at our lower level of care patient days. We have had great success in this metric. Looking at our baseline last year of 1,192 days, we've been able to stay under 850 throughout this calendar year. Our goal was to be under 950, and our year to date is 786. So we are in the green. The next metric looks at our OR block utilization. And here we are looking at the percentage of surgical services that have above 80% utilization. So there's 10 surgical services, and our goal is to have 8 out of those 10 that are using 80% of their time in the OR. And as you can see, from March until June, we had 9 out of 10. In the past 2 months, we've dipped down a little bit to 70%. This still keeps us in the green with a year-to-date of 83%. The next metric is our bed turnaround time. So the time between a patient being discharged from a room until that room is ready for another patient to come in. Our goal is 60 minutes. We have hovered around 80 to 85 minutes, but in the past couple of months, we've made some improvements and we've gotten this down to about 74, 75 minutes with a year-to-date average of 78.8. So we are in the red there, but we've been making progress. And lastly, within our quality composite, we have our third next available appointment rate for new patients. Our metric here is looking at the percentage of clinics that have a third next available appointment rate less than 21 days. And you can see that we have hovered around 80 to 70% with this one as well. Our goal is at 90% of clinics are less than 21 days, and we currently sit at 74.5%. So we're in the red with this one. Next, we have our care experience metric. This is looking at implementing our real-time patient survey. This metric measures key targets that we have 7 different areas that are going live with this. We hope to achieve incrementally as we go through this calendar year. So you'll see that we have a target to get to 66% by the end of this month. And currently we sit at 42.9%. So we met our August 31st deadline of being above 33%. We are on our way to meet 66% by the end of this month. Developing our people. Again, this is looking at a similar type of metric. We're looking at the number of measures that are achieved by our 4 different focus groups. You can see that we have a goal of 66% by the end of August, which we met. Our next goal is to get to 100% of all of these targets being achieved by the end of the year. And I believe the team will talk a little more about that one next. And then finally, we have our financial stewardship metric, which looks at our salary variance. We are in the green. It looks like we are in the red, but with COVID, we are still reconciling some of the variances, and we expect this number to go back down once we are reimbursed for that work. So that is our key performance indicators on our scorecard, and now we have our outcome metrics. So these are our longer term metrics, 3 to 5 year metrics. These haven't necessarily changed in the past couple of years. We'll go through them right now. We have our Black African American heart failure readmission. You can see that we've stayed around the 20 to 30% with a bit of a jump in June, but that came back down to our mean there in July, and we are below our target of 34.3%. You're sitting at 23.7% 30-day readmissions. Cms Star Rating has been 1 star. Our goal is to get to 2 stars. A lot of our metrics that we have above in our scorecard are related to this in hopes to move this again from 1 star to 2 stars. We have our likelihood to recommend hospitals to family and friends. Currently, this sits at 78%, which is just below our target of 80%. And this is looking at those top box positive responses per survey that comes back to us. And we have our likelihood to recommend Zsfg as a workplace. This came from our staff satisfaction survey a couple years ago. So this metric is sitting at 3.66. We will update this with the new survey results and then some of the work that the developing our people team is undergoing. And then finally, we have our general fund spent and not exceed budgeted amount, which is still in the process of being updated for the final quarter of the fiscal year. But the data that we do have, we were on target with 2.31 million and be under 25 or 253.04 million. And with that, I will take questions from the commissioners.
Mark, do we have any public comment?
I will check, sir. Folks on the public comment line, if you'd like to make a comment on item 5, the True North scorecard, please press *3 to raise your hand. *3. No hands, commissioners.
Well, thank you. Any comments from our commissioners?
I don't see any hands over there either, but I'm not sure if they want to verbally just jump up if they have any questions.
Okay, right. I think the one I have some concern about is the issue of falls that we seem to have chronically, and are we looking at different measures to try to help bring that down? But you know, I know it's been a continued problem, but just following a metric doesn't help, right? So are we taking more more action on it?
Commissioners, I think I can probably take a stab at answering that. Just before this meeting, Leslie Safia, myself, Justin Dortman, and Dana Frazier, along with Lisa, Winston met to discuss this very topic about our falls program and where we were at with our falls program, and to really do a deeper dive into the data. And what we've actually seen when we look at the data really closely is the overall volume of falls is fairly steady, but in the last 2 years, we have seen an increase of falls with major injury, which is concerning to us. So we're looking at that data, and we're beginning to put together some new work to ensure that what's being done continues, and to discover if there are new ways to use some of the adjuncts we already have. We understand that there are additional risk indicators that may be available in EPIC, and we're going to look at the availability and the usefulness of those. We're also going to try and better understand if there are any commonalities between the falls. At face value, in an initial review of the data, there didn't appear to be any trend other than there was a commonality around time of day, and there was a lot of discussion around what the patient was doing when they fell, and it seems there's a big correlation to toileting for patients and that's when many of the falls happen. So and we're also beginning to really discuss as to the works that we have done to reduce the overall volume of falls has been ongoing, and we don't see an upward trend in the overall falls. So we're beginning to look at what evidence is out there to begin to really consider whether we move towards an injury reduction program as opposed to an overall falls reduction program. So there's a lot of thought going into this.
Very good. I'm pleased to hear that. Also, I'd like to welcome back Dr. Marks. I'm hoping that he finds it pleasurable that he is now back at General. I think the COVID environment might have been really, and it was a great challenge, and you deserved not just a day, but a year for the work you did. And so, but I don't think the mayor has ever declared anybody for a whole year. So our congratulations to you on that. And we look forward to having you as a participant again back on our JCC. Thank you.
Thank you, Dr. Chow, for your very kind words. I'm very excited to be back and have the opportunity to apply some of the things we learned during COVID, especially around analytics and predictive analytics, to addressing some of our long-standing performance challenges.
Well, thank you. I think my final comment is I really appreciate it that the colors are in a separate column, because it didn't obscure the number. And I just pointed out to Leslie as to whether or not they might want to do that in their reporting also under the quality measures, because it does make it a lot easier to be able to read the actual numbers. And of course, the colors help greatly in understanding the status. So just a comment since we were looking at both of these scorecards, and the colors are quite helpful already. Do we have any other comments either from commissioners that might want to add, or we can otherwise go on to our next item, Mark?
Dr. Chow, if I may, I also want to make sure I've welcomed Jim back many times. Super excited to have him back with us, and especially to work on some of the exciting data analytics projects that he's so incredibly talented at. I did want to make sure, I know Dr. Green posed a question about the metric details for access and flow during COVID-19, and I didn't want to pass by that question. I personally wasn't quite sure I understood what it meant. So maybe Dr. Green, if you could clarify that, we could get your question fully answered.
Oh, well, thank you. No, I didn't focus as well, but I just wanted to understand when you look at the access and volume, just what this metric is compared to what you anticipate in the future as things slow down with COVID-19, and how this might compare to what was going on with COVID-19. In other words, I was going to get a little sort of context about, how this fits into past and future.
Sure. Well, I can take a slight stab at that. So first of all, the metrics that we're looking at are not different, I would say, from what we would have looked at before or after COVID, but certainly COVID has an impact on those metrics. For example, the one that we really are having an issue with right now that we weren't having an issue with earlier in the year is ambulance diversion. And the direct impact, well, the indirect impact of COVID is really nursing staffing, affecting our ability to have all of our beds open. So it's not really COVID per se, but it's the environment in which we're working that has led to a pretty significant nursing shortage around the country that affects that metric. Likely Dr. Day would say that our ability to keep to our third next available appointment goals is also impacted by COVID, and staff who may have been deployed or internally to do COVID related things and not be available in the clinic to provide services. So there are definitely impacts of COVID scattered through there, but the metrics themselves I don't think are different than what we'd want to look at in the absence of a pandemic.
Thanks. So really, that would be what's driving it into the red as opposed to anything else, really.
Well, that we could say that, but the truth is we were having trouble with ambulance diversion before, but for entirely different reasons. Not entirely, but different reasons. So I think these metrics reflect challenges for us that are different at different times. But it makes it really, they're really obviously super important to our work and our ability to serve the community and our patients. So we will continue to focus on them as time goes on.
Thank you so much. And it's remarkable, really. I know the SSI numbers have gotten better in several of these things. The catheter associated urinary tract infection, we talked about how that metric is going to improve. So it seems like these are going to absolutely look better as time goes on, and the numbers are tiny. A few here, a few there. So it's hopefully there isn't that much of a lift to pull these in, the ones that you want to bring into green to do so.
Thank you.
I'm all for green.
Okay, are there any more comments? If not, we will call the next item.
Sure. Thank you, Chris. Item 6 is developing our people strategic plan.
Good afternoon, commissioners. My name is Ayanna Johnson. I'm the Chief Experience Officer at Zsfg. And I'm here with my colleague, Margaret Damiano. And Dave Woods would usually be here, but he is off today to present to you our A3 work on thriving at work. I believe Margaret's going to be pulling up the slides in a moment.
Hey, Mark, could you give me rights and then I can pull it up?
Oh, sure, of course. Just gave it to you.
Okay, thank you. I think we're ready to start. So if we could go to the next slide. Of course, we always start with our true north. And in regards to staff engagement, I wanted to share kind of the alignment with staff engagement to true north. So in order for us to have a staff engagement strategy, we really need to have a strong foundation, which is built into who we are, which is why we exist, our mission and vision and values that you see here in our triangle. And in order for us to meet our true north goals, though, we are reliant on our resilient staff and providers, and they are our most important resource. And we are committed to our staff, and this work is really being driven by the true north goal, developing our people. Next slide. This year, I think we've all, in every presentation that you probably heard, you've heard about our work being disrupted because of COVID-19. And that has been especially true for our staff. The way in which they work and how we honor them has completely changed as a result of COVID. And COVID has elevated the need for us to really focus on human experience principles. So the A3 that you see on the slide and what we'll be sharing today is really grounded on how we drive organizational change. Next slide. So in order for us to do this work any justice, I really, we felt it necessary to share with you our journey. So how we arrived at where we are. So in order really to take a look forward, we need to take a look back at what we've done in terms of staff voice. So in the past 6 years, which you see on the screen, we have surveyed our staff a total of 11 times. And there's multiple surveys. There's surveys that were led by DPH. So it was a UC, it included UCSF providers and DPH staff. There were safety surveys. There was also an equity survey. And in the last year, we've actually conducted 6 surveys. 2 of them have been from UCSF, administered by UCSF. And then we have done 4 pulse surveys. And pulse surveys are really our way of taking a pulse of our organization about how they're feeling about certain focus areas. Next slide. So the surveys have really informed our strategies around developing our people. And what I have on the screen today is the evolution of our strategies. So it started with developing our people, is what our strategy was called, and it was really focused on advancement and succession planning. Again, we assumed that this is where our focus should be on in relation to staff engagement. We then shifted to be more inclusive, and we had a more inclusive title called Workforce Care and Development. And we were still committed to the success of our workforce, but we also had a balance with the well-being of our staff and providers. And then we conducted a DPH-wide survey that surveyed our DPH staff and UCSF providers. And we really wanted to become a better place to work. We had pretty low scores on overall engagement, and our focus was on the indicators for overall engagement, which was how are we going to retain talent, how are we going to keep people wanting to come back and being joyful about their work and having the resources and tools to do their job safely. And now we've gone from kind of survival mode for the last 18 months to really wanting to be at a place of thriving, because being in survival mode is just not sustainable for our workforce. So our focus is on a strategy that really aims to place staff in a place where they are thriving. So we want individuals to be high performers, but we also want them to come to work and feel good about coming to work. Next slide. In addition, I think in order to do our journey justice, we have to also share that our organization has gone through incredible change in the last 6 years. So in 2016, we moved into Building 25. In 2019, we implemented Epic, so we changed the way a lot of our staff worked. And then shortly after, we entered this global pandemic. In between these 3 momentous events, we've had multiple surveys in terms of relicensing. So we've gone through quite a bit of change, and in that time, we've also surveyed staff and obtained information about what they need from us. Next slide. But to focus on COVID-19, I think that has really elevated our need to really step up our game around staff engagement. So this pandemic has really driven us to address our staff's basic needs around safety, stability, and security. We've had to think a little bit more about how we engage a more fatigued workforce, right? We're at, I think, closing out of our 4th surge. And then how do we reintegrate staff who have been working remotely or activated, like Jim, who shared that he is finally back. We have many others like him who were activated for quite some time that are now re-entering. But I think the main thing that COVID-19 has showed us is the importance of human experience principles and what that means to our staff in relation to these focus areas of communication, wellness, staff safety, and recognition. So I'm going to hand it over to Margaret so she can share the remaining slides.
Should I give permission to her to do that? Or just the same slides?
I think she just needs to unmute.
Oh, okay. I can unmute her.
Oh, thank you.
You're unmuted, Margaret. She's not able to, so I'm not sure if she's not able to talk. But she is unmuted.
Okay, I can continue if that's okay. Yeah, I think she says it's okay. Again, you know, this is a joint effort, so we were trying to divide our slides, but I'm happy to do this. So our current conditions, so where we are currently, the one thing that comes to mind, I think, from the background slides that I shared is the 11 survey efforts. We've had many, and they're not all aligned. So we can't compare apples to apples, and that creates some issues in terms of implementing improvements that are going to address all of our areas of opportunity. When we talk about staff engagement, it's important that we also bring up how it interfaces with other areas and efforts that we are working on, such as equity, safety, patient experience, to name some. And the other piece is that not everything that is important or of value to our staff is within our control. So when we've surveyed staff, they say, you know, free parking, free food, bonuses are things that they would like, and we would like to give those to them, but that is not within our control. So it's balancing the things that are important with the things that we can do. Next slide. So of the survey efforts, I'd like to focus and share with you our 4 pulse surveys that we've conducted in the last, these are 4 surveys we conducted. 3 of them have been in the last year. One of them was kind of our foundational survey, the 2019 staff engagement survey. And so that's what you see here. So the different bars are the different surveys. The dark blue is the 2019 DPH engagement survey. So that's kind of our baseline. The other bars are our pulse surveys. And what you see is that we've had some increases, but we've also had some plateaus. Where we are now, which is purple, is basically in all areas an area of opportunity, particularly around how we balance staff who are burnt out and stressed, and how we recognize our staff. Safety is one of our higher performing areas, but still we have gone down since our 2019 survey. And where you don't see bars, especially around the safety, is because those questions were not asked in the previous pulse surveys. Next slide. So our problem statement is, despite our efforts around staff engagement has not improved, and we are not achieving our True North metrics. Next slide. So our targets and goals are really process measures. We hope that these process measures set us up to see some outcomes. So the first is working with our 4 areas. So each area of recognition, safety, wellness, and communication has a leader that is going to be leading an A3 with a designated team, and they'll have a metric that they'll be working on. And our target is to have 3 out of those 4 metrics on target. The next one is operationalizing our work strategy, our Thriving at Work strategy. So for us, that includes 3 components, meaning the first, that we have a leader confirmed for each of the focus areas, that we have a multidisciplinary team for each of the focus areas, and that by the end of the year, each area has a completed A3. Again, so that's using the data to inform improvements so that we go and actually have some actions out of it. Next slide. 2 of our really important countermeasures that we're in process is developing a framework that aligns with our data. So this is something that we will be working with the leaders on. And then also, as I mentioned, to develop these A3s for each of the focus areas. Next slide. I think it's really important to also recognize all that we've done as we've continued to navigate through this pandemic. As I mentioned before, COVID-19 has been our burning platform, and we have done more in the last 18 months for staff engagement than we have in the last 9 years that I have been here. So I wanted to share some of the things that we have done in each of our focus areas. So around communication, we've done, I think, the most around communication. We have a daily digest email that basically is a digest of all communication related to COVID and non-COVID that gets sent out to all staff. We also established an all staff email list. We didn't have that before. So we were dependent on individuals sending it to their networks or direct reports. Early on in the pandemic, we had a COVID-19 focus bulletin that had information around the dynamic changes that were occurring with COVID. And I know one of the most popular forms of communication has been Luke's email, which he sends out, which gives kind of a rundown of status of all that's happening in the hospital as it relates to flow. We also have done some work around staff safety. So as a part of the health orders that have come out, our alignment with those around staff screening. And also we've reconfigured the lobbies. So we've gone from a very porous open campus to a very closed campus and received some really good feedback from staff around that. We've also been very transparent about our PPE. We have an employee hotline that we've never had before. And we've also have some de-escalation trainings that we've continued throughout this pandemic. In terms of staff wellness, we now have the 24/7 spiritual care support for staff and patients. We've also instituted a wellness walk, which is kind of a half-mile perimeter walk around campus. We've have and will continue to do some chair massages. We also have Zoom exercise classes. And then in regards to staff recognition, we've received a lot of donations at the beginning of the pandemic that we spread out, I think, for the first year. Those came through as a lot of food, and staff were very appreciative of that. We also have an opportunity to share feedback, positive feedback about our colleagues and team members through a staff shout out page that gets published daily, and then also in our TV screens on our main corridors. So we've done a lot, but there's so much more work that we can do. I think what we've noticed is that this is important regardless of whether there's a pandemic or not. Next slide. So our next steps is to communicate to the organization our survey results. I think it's important for us to close that loop. Again, develop our operational A3, so turning our data into action. We do have plans, the DPH does have plans to administer a larger DPH-wide survey. The last one was in 2019, so we're overdue for that. And then UCSF just closed out 2 surveys. So once we get the DPH results, it's really going to be aligning our data and looking at what actions that we can identify from all of those survey efforts. So with that, I'm going to conclude the presentation and open it up to any questions that you may have.
So Mark, is there any public comment?
Sure. Folks on the line, if you'd like to make comment on item 6, please press *3 to raise your hand so we can acknowledge you. *3. No hands, commissioners. And I don't see hands from other commissioners, Dr. Chow. Oh, I'm sorry. Commissioner Green has her hand up.
Yes, please, Commissioner Green.
Yeah, well, thank you so much for this work, and really the deep thought and analysis that you're doing is really terrific. I was wondering if you have any more granular detail on this in terms of, whether there's certain employee classes in particular that you see more disengagement than others, and the extent to which what Dr. Ehrlich was saying earlier about staff shortages, how you feel that weaves into, your ability to really achieve, especially some of the stress reduction, because that's certainly one of the biggest stressors is getting to work and not knowing, what your assignment will be or who will be there or whether other people have called in sick. And that's certainly on some service aspects of work there, but not all. But do you have any sense of areas of particular vulnerability, any groups?
Yeah, that's a good question. So for our 2019 survey that we did have received granular data for the pulse surveys to preserve anonymity of our staff. We did not ask those questions because it was not administered by a third party. So there's hesitancy around responding when you're asking a lot of details. But I will say from the latest pulse survey, the largest group to respond, which is the emergency department, they had an overwhelming amount of responses, followed by the Department of Medicine from UCSF. So I know that with the 2022 DPH survey, we're going to be receiving, it's going to be administered by a third party. We will be able to stratify by classification, by full-time per diem. So we'll be able to see where there are opportunities and disparities. In regards to staffing, you know, when we ask these questions around safety, wellness, recognition, communication, we asked an open-ended question for each. And I think for every single question group, staffing came up. So staffing as it related to communication, as it related to recognition and wellness and safety. So I think it's on everyone's mind. And I think one of the things is people want to feel like they have the resources to do their job, and that means being staffed, right? So I think that is definitely a huge component of staff experience, especially at this time.
And then I may have missed this, but when you look at your subsets of employees, you know, nurses versus, you know, porters versus pharmacy versus lab, have you got any breakdown there, or you know, when you look across the whole organization and all of the different multiple employee categories, are you getting information on all and being able to kind of see if there are commonalities among them?
Yeah, so we for the pulse surveys, we did ask for departments to report departments, and I think there are definitely some commonalities amongst all areas that we've been able to kind of group together. So around, you know, but they also, it's interesting, they respond, and sometimes they respond on opposite ends of the spectrum. So for example, for staff safety, there were some that were very pro having security on campus and sheriff, and then there was others that don't want that. So it's on both sides, and it's now up to us to really, what is that balance that we want to strike, right? I think that there was some commonalities around communication in terms of having different modes of communication, so not just being email centric. Wellness included, you know, being considerate of time off. That's also very hard to do with the current staffing situation that we're facing. And let's see, around recognition, there a lot of the things that are not in our control were at the top of the list around, you know, promotions, salaries, and parking. But I think the one thing that is within our control was the request for direct supervisor recognition. So when we asked, how would you like to be recognized? I think the most meaningful way for our staff is from a direct supervisor. So I think that we have something to work with there.
Wonderful. Thank you so much.
Thank you. I was looking at your data, and I do think it looks like in your pulse data on the 4 surveys that the communications has certainly improved from your baseline from 2.87 to even 3.06 is not so bad. That's at least an improvement, and you've done so much in communication, not just and presumably after COVID we're going to continue to be able to communicate, because that seems to be a real thing. And I think your discussion with Dr. Green certainly pointed out the challenges in wellness and recognition. So I'm grateful for her to having asked those, because that was also what I was going to ask, what you were looking at in terms of trying to improve those. And I think first is you have to recognize the problems, and you have over these years, and you're also seeing that there are moving challenges, and it does sound like staff shortages is one of our biggest ones. I guess we could look at that when we are looking at the personnel, at the hiring reports, and seeing is there anything there that could be helpful. But and we'll ask our hiring officer to comment on that, because I think Now we've heard for the emergency room, for some of our wellness and recognition, there really is a problem of hiring. So I think we need to kind of focus, well, what are we talking about and why is that continuing? Aside from a shortage of nurses, it looks to me like a number of other services perhaps need to have a more full staff. So thank you very much. It's really great to see the flow of your surveys and the challenges and not having the same questions, but being able to pull out really the important issues that you're facing. So it's a report of work in progress, and we really appreciate that that's being done right now. Thank you. Mark, shall we go on to our next item, please?
Yes, sure. Thanks, Ayana. Item 7 is the CEO report, an emergency department newsletter.
Good afternoon, commissioners. I first want to extend gratitude to our presenters so far. You know, they all work so hard to put all this information together, and we work, you know, really very hard as a team to make sure that you get, you know, this information. So I want to thank Leslie and Chris and Ayana for putting all this together. I have my report for you. There are several items that are written. I won't go into these in detail. I think you heard a little bit about our successful surveys in radiology and in the outpatient opiate treatment. And so I won't go into that unless you have more questions. And then Environmental Services Week was really nice to recognize our very important group of environmental services workers who are working, you know, really hard to keep us safe and clean here every day. Any questions about any of those items or anything else before I move into the data?
Commissioners, any questions? I guess we'll move into the data before we ask for public comment. Thank you.
Sure, and I'll take hands for the other commissioners.
Okay.
So looking at the number of COVID patients at Zsfg, you know, when I look at this, I think about gratitude again, that our fourth surge hasn't been anything like it might have been in other parts of the country because of our successful work in vaccinating the community and also with just being good about wearing masks and distance and taking care with those kinds of measures. We have 15 COVID positive patients in the hospital today. So it's definitely not, we're not out of the fourth surge, but it is not anything like we had, you know, earlier in the beginning of 2021. Moving on to the other volume, you can see that in the emergency department, indeed, our daily volume is going up a little bit, and admissions are, you know, haven't changed that much. But what you do see really large increases in are our leave without being seen and triaged rates and our ambulance diversion rates. And those two things are very related, as is suggested in the lines. And at this point in time, they really are related to our ability to, or inability at this point to staff. And I know we talk about staffing in all of our meetings. I just do want to make the comment that this is really not just, it's not a local problem. This is a national crisis with healthcare workers, and you know, no better time to be talking about staff engagement and joy in work, because we really need to double down given where we are in this circumstance. So ambulance diversion is extremely high. It's much higher than we would like. I know we are making a number, we have a number of countermeasures in place to address our workforce. And I know that'll come out in our HR report. And I really am grateful for the partnership we have with the HR to address a very challenging circumstance overall. I will say, and this is a much bigger topic, that we do have a vaccine mandate that is going into effect on Friday, and that is not going to help matters. Again, we're working with HR very carefully First, to make sure our teams understand what the mandate is all about, and that we are supporting them in making the best decision we can about getting vaccinated. We have very few people at Zsfg who remain unvaccinated. When you look at it as a percentage of the whole, but anybody going off work at this time is a problem. So we are working through that. Very large topic, and there'll be more to come. And it's also a very dynamic thing. I just want to mention one of the things that I've been very glad to do, and my team has been very glad to do, is to partner with the union on this. So SEIU miscellaneous leaders have been very interested in reaching out to their members to make sure that they make the right choice to be vaccinated. And they're hosting a forum tomorrow with some of our healthcare providers and their membership who have been vaccinated, so they can actually encourage folks to be vaccinated. That's been a really nice partnership to have in all of this. Moving along, you can see that that urgent care has been a fantastic partner with the emergency department in ensuring that patients are seen at the right time in the right place with the right service. The urgent care clinic is really just truly amazing in terms of the volume of patients that they've been able to accommodate. And so you can see that the volume is going up in urgent care, and they're seeing around 100 patients there a day. The psych emergency has not changed that much. The average daily PES encounters are more or less the same. The admissions remain low, mainly because of our inability to move people out of the acute care setting. And hopefully our city's work in mental health SF will make that easier as time goes on. I think the only other thing I want to say, well, two things. The lower level of care numbers have never been better. Talk about it, a formerly intractable problem that has gotten much, much better on the med-surg side, especially. So I am very appreciative of that team, especially during this time, and keeping those numbers low. And you saw that in our True North scorecard. And then lastly, about vaccination here at Zsfg, I wanted to take this opportunity as we look at that data, Dr. Green, to address the other question you had about boosters. So we have, obviously the news about that has been unfolding over the course of the past few weeks. And we will start to be administering boosters here. And I wanted to turn it over to Dr. Day, who's leading that effort, well, all of our efforts on staff and patient vaccinations. So Luke, thank you for addressing that.
Happy to. Thank you, Susan. So it was a great question to ask regarding where we are with booster vaccinations. There's been a lot of excitement, but also a lot of uncertainty around it. So we just got approval from the Western Scientific Board and then also the Department of Public Health to move forward on administering a Pfizer booster shot to individuals who had received the Pfizer vaccine 6 months ago. And it falls into a couple of categories. So all healthcare workers, which all our staff fall into, anyone over the age of 65, residents of long-term living facilities or skilled nursing facilities, and then individuals under 65 who have several chronic medical conditions. So starting tomorrow, we will be activating our patient booster vaccination program, meeting sort of those three criteria. We're actually starting tomorrow to vaccinate all of our long-term care facility patients, both on the inpatient psychiatry unit and in our skilled nursing facility. And then the outpatient setting, addressing our elderly patients and individuals with chronic medical conditions. And then starting tomorrow, all of our staff who received the Pfizer vaccine over 6 months ago will receive an invitation to actually sign up to receive their Pfizer booster vaccine starting next week. Many people have questions around Moderna and Johnson & Johnson. We're still waiting for further guidance on those, but we believe that that will be forthcoming in the next couple of weeks where additional boosters will likely be available. We have a lot of staff that have been mobilized to help support both these efforts. but we think we'll be able to meet the need of both our staff and patients over the next couple of weeks, while at the same time making sure that our unvaccinated staff and patients also have easy access to receive them as well.
Thank you, Luke. Yeah, and I definitely want to say, our first priority always is going to be to vaccinate the unvaccinated. So we want to make sure, that we always are maintaining capacity for those folks to come in and get vaccinated. And you had a question about capacity as well, Dr. Green. I think, the first time around when we did the initial vaccination effort, we started by offering to staff and to patients. And then as time went on and we had more ability to do so, we opened our doors to the entire community. So I think you'll see we're taking the same approach now. We're really focusing on staff and we're focusing on network patients and uninsured. And we're encouraging people who have healthcare coverage of other types, and who have access, or patients of Kaiser, Sutter, Dignity, to get their vaccines there. They can also go to pharmacies in the community that provide a huge volume of those vaccine as well.
Thank you. I think at the peak of this, you did about, I guess if you add the staff and the patients, close to 2,000 a day.
That's right.
And do you anticipate, I mean, so many things are coming together, and then, down road when Moderna boosters come along, we'll probably be doing the children. So I with the nursing shortages and all, are there any concerns about what is the capacity we have, and how do we make sure that the right people are coming to the general, because the word is out that that's where you can go.
Would you like me to answer that, Susan, or?
Yes, please go ahead.
Yeah, no, it's a great question. And we've been very mindful around sort of the staffing constraints. So we have been fortunate enough that we still continue to have some disaster workers from the state. So we have those resources actually through the end of December. For our outpatient vaccinations, we're reducing it down to about 1,000 patients a day we can actually still vaccinate very comfortably with our current staffing. We have been pretty active in trying to message out to the community. So we have a lot of signs on campus really advertising that we are vaccinating network patients or uninsured patients. And then also we've been working with our other community partners in the city. I think one of the things is we're in a different state. So before, where there was vaccine shortage and not a lot of sites early on, I think that luckily has gone away. So I think more people are comfortable going to even their local pharmacy to get it. And then for staff, we can do up to about 200 to 300 staff members a day in our current setting. The other thing we have also done is we've coupled the flu vaccine with COVID vaccines and booster vaccines as well too. So there's no contraindication to getting both. So our flu campaign actually started just a few days ago, and it's in the same location.
Thank you. Well, it'll be really interesting to see how your numbers on this flow. And will you be doing any breakdown in terms of which are boosters, which are, as we move forward with our data, will we get any more detail about, how much is a first-time vaccinee, how much of his boosters, how much are the staff that haven't gotten vaccinated to date, and so forth?
We can provide that, yes.
Thank you. Very interesting, very interesting. And I hope the other systems come through.
They have been good partners. We have our hospital council meeting almost every week, and this has definitely been a big topic of discussion.
Great.
Thank you. I know. Mark, shall we see if there's public comment on the CEO's report?
Sure, yes, sir. Folks on the line, if you'd like to make comment on item 7, this CEO report, please press *3. Raise your hand. *3. No hands, Commissioner.
Thank you. I was just going to follow up with Commissioner Green's question and Dr. Ehrlich about the hospital council, and I do know that the medical staff at Chinese Hospital has extended the opportunity to have a booster shot over at the hospital. I think they've set up already 2 different clinics. So hopefully our hospitals will all be doing that for their regular staff also as they go along. Of course, I don't get the regular staff notice, so I'm assuming they're doing it also for the regular staff, and that would certainly be very helpful. Well aware also that vaccines are now easily available by way of the pharmacies, as Dr. Day said. So we're hoping that won't be a large influx, but that will continue to do the unvaccinated also. I was wondering though, as we're talking about staff shortage, while the numbers here don't look like they're large in terms of the number of positives coming from staff here, do our protocols then keep people out of jobs for a period of time if they have a COVID positive, or are we also asking people to shelter who might come back from vacation and whatnot, and therefore that contributes to some of the shortages? Yeah, I guess in short, what is our policy of people coming back from other areas, and does that contribute to them having to be quarantining or time off?
Yeah, I'll let Luke address that. We have a very active occupational health service that deals with, that manages calls, manages whether or not, invites people to be tested, has them off of work, brings them back to work. It's quite active, and they've done a remarkable job. But yes, the short answer is yes, this does contribute to us having shortages of staff when we have folks who need to be off work because of their COVID exposures.
And one of the things we did early on is we expected that we would have more significant staffing shortages at the beginning of the pandemic. We had heard upwards of 10 to 20% of staff could be infected with COVID and not be at work. And so part of our surge plans have built in how we would leverage staff across the entire campus. And I really want to sort of thank Terry D'Antoni. She's been instrumental in actually pulling a lot of that together. Really thinking about once we start reaching critical staffing, especially on our inpatient and emergency services side, we would then move to our outpatient setting in our procedural areas and start pulling staff from there to help support our more critical services should we start developing staffing shortages.
Okay. All right. Good. But we do know a number of people travel, and so we know that Laguna has a policy for, I guess, for that sort of circumstances. Is that a similar policy? Do we have a policy here in general if people did travel? Because that certainly is questionable. I guess some people would say you do a COVID test and you can come back to work. Or if you didn't have contact, you can come back to work anyway if you're not symptomatic. So what's our guideline in regards to possible exposure?
Do you want me to answer that, Luke and Susan?
I was going to say, does Lisa want to answer? I think she could probably give a more clear and thorough answer.
I will be brief, and then I think Will Hewen is also on, who can also address this question. Yes, we do have a policy. It's actually been updated a number of times with the CDC guidance on this, which has changed. But just in general, if you're vaccinated, as long as you're asymptomatic, you can come back. But we do recommend testing. In some circumstances. There are some circumstances for international travel where those who have not yet been vaccinated, when they return, there are some requirements for testing and previously needing to be off work. The main, besides folks who have COVID, the main reason people are off work for an extended period of time is if they have a household member or close contact outside of the hospital who has COVID, and then they're required to quarantine. But occupational health here actually has quite detailed protocols that they follow and keep updated.
Okay, no, thank you very much. Are there further questions on the CEO report or further comments from anybody?
I don't see any hands, Commissioner Shaw.
Okay, good. Thank you. Then let's move forward to our next item.
Thank you, Dr. Ehrlich. Item 8 is the hiring and vacancy report. Carrie.
Hello, commissioners. Good afternoon. For the HR report, we have total vacancies are at 9.35%. Last month, we hired a total of 28 employees and we had 13 separations. As Susan mentioned, definitely in our awareness this week is September 30th is the deadline to be fully vaccinated per the COVID vaccination mandate for Zsfg employees. And although we anticipate the number of unvaccinated employees to go down each day, we are preparing for these staffing gaps. The RN vacancy is up to 7%. And to mitigate those challenges in hiring nurses, we are onboarding 29 as needed nurses to assist with backfill for September and October start work dates. We are establishing an all DPH hiring team for nurses, which includes HR staff for position approval, exams, recruiter, operations analyst, a nurse, and onboarding clerks. We will have another status update in October to provide you where we're at with that team. The goal is to streamline expediting hiring and provide dedicated and sustained focus on nurse hiring. And I did attach in the presentation a proposed organization chart with the duties. Due to the mayor's declaration of emergency orders, we received the approval to hire critical COVID-related permanent civil service employees without an adoption of an eligible list. We started the process over a week ago now to fill positions for 2320, which is nurse classification. This expedited merit process will get applicants faster in the hands of our hiring managers, and thus will speed up the time from application submission to selection. October 2nd and 3rd, this weekend, we are working very hard partnering with the hospital occupational health and Terry's team. We're hosting an RN expedited onboarding event at Zuckerberg. We will conduct one-stop shop fingerprinting, medical appointment processing, and complete the paperwork that the candidates need to do with HR, targeting start work dates of October 16th. Pending clearances, and those that don't clear that week will continue to process them as the weeks go on. Commissioner Green, you provided a couple of questions in email. One was in regards to the BERT team that I mentioned in the report. You asked if this would be streamlined or there would be delays on this. To update you with the BERT plan, we've been working closely with the director, Kathy Ballou, at the hospital. And we have the approval to hire the classifications without an eligible list for these, for the licensed psych techs. There are 23 FTEs. That is an extremely challenging classification to fill. We generally do not get a lot of applicants for that. And for 5 psych nurses. So this will expedite selections as long as we have applicants. And as we know that candidate pool is very small for the licensed psych techs, we are looking to substitute or replace some of those classifications of the licensed psych techs for LVNs. Our LVN pool is much more robust. And right now, this week, we've already received about 20 candidates interested in our canvas. We sent out a notice to all LVNs on our eligible list to see if they're interested or if they have any psych experience. And if they do, then we can modify some of those originally planned licensed psych techs to LVNs so that we can fill these positions faster. And the second question was in regards to the HRRN team structure. It was how will the Racial Equity Action Plan be incorporated into the jobs and appointments. And we align our merit job announcements and our selections following the hiring process and equity review of selections for RNs as we do for all recruitments. This team, though, will focus and address diversity challenges for RNs, public health nurses, and P103s. We know that it could vary in the attention depending on the availability of the candidate pool. But we'll be looking at that absolutely with all of our hires. The REAP or Racial Equity Action Plan is forefront in our hiring processes. Karen is available on the call if there are additional questions in regards to the RN team plan, but I'll open it up now to any questions.
Shall we ask for public comment first?
Commissioner, there's no one, there's only a staff person on the line, so there's no one from the public.
Oh, okay. Good, thank you. Looking at the HR team structure, just taking up from there, amongst the 10 people plus your plus Karen, there is one recruiter, and is that how it works? I mean, we have one recruiter, and then it takes an army to put them through. Is that it, or should we have more recruiters and less staff? I mean, it sounds like block of people supporting it, but I don't know if one recruiter is enough or not. I'm sure you've thought this out.
Karen, go ahead and update.
Hi, Commissioner Child. This is Karen Hill. Hi, I'm having computer issues, so I see my name twice, but I only can call in right now.
Okay. Thank you.
So to answer your question, we don't know what we don't know right now. We only have the one recruiter assigned to this team because we only currently have 3 recruiters for the entire Department of Public Health, and this recruiter we had already had assigned to do RN hiring when she was first hired, a couple of years ago, and is focused on RN hiring, and so she's the most experienced with recruiting RNs. This may not be enough because we're just establishing this team. We're looking to use the resources that we currently have and learn from it in the next year. We'll use the resources that we have over the next year, and then we'll revisit come next year and see where the gaps are, and we will create another staffing model to show where the gaps are, and if it looks like we need more resources in the recruiting area, then that will be our ask during budget time. But right now, I'm only pulling the resources, the positions that we have. If you see the structure, these are not new positions, these are existing resources that we have, and we just of course don't have any funding to ask for new positions at this time. So we're hoping by this time next year, we'll be able to evaluate the team and see again where the gaps are, and then make a request to our finance team to build from where we are.
Well, thank you for that insight and the explanation. And Commissioner Green.
Well, I just want to say how impressed I am by your creativity here, because that BERT team and how to staff it was really a conundrum. And to think about, I mean, this has been something I know Secretary Morowitz has brought up many times about, how can we really utilize individuals who may not have the exact credentials that were, identified when things were not as challenging, and utilize people and bring, it's part of staff development too. How wonderful to start with LVNs and give them this potential skill, which will serve them so well and give them an opportunity to really expand their career satisfaction. So I just wanted to compliment you for that kind of pivot. I think it's terrific.
Thank you.
And I want to thank the HR team. It was clear that today HR again becomes very important in the spotlight, and we'll be following carefully how these expedited programs can help in filling the gaps, which we've already heard have been causing some of our delays or difficulties in meeting certain goals. So thank you very much. Are there any further discussions on the HR from anybody? And not seeing that.
Any hands?
No hands, huh?
No hands, sir.
Okay, then let us thank you very much, and let us move on to our next item.
Great, thanks again, Carrie. Item 9 is the medical staff report. Dr. Winston.
Yeah.
Thank you. Good afternoon, commissioners. My pleasure, as always, to present the Chief of Staff report I will start with the items that are for your information and then move to the items for potential action. So the first informational item, we wanted to let you know that Dr. Joseph Cuccieri, who is our trauma chief, was gratefully on our part was appointed as the interim chief of surgery starting September 1. And recruitment it will be underway for Dr. Deborah Stein, who has decided to move back to the East Coast. And I believe you have his CV. So we are pleased that he will serve in the interim surgery chief role. And then we also wanted to let you know just on an informational piece, because it has been discussed in the past, that DEA certification is required to work here in a clinical capacity. And so we have updated the letter that will go out to staff who are not current on their DEA. So it will be clear to them, that this is required and what the consequences are if they do not apply. They will have substantial time though to complete that, and we can help them if they have any questions or concerns. And then we were very fortunate at the Medical Executive Committee meeting this month to get the clinical service report from Anesthesia and Perioperative Care from Dr. Romaine Paraccio. And this was a really wonderful report that reviewed all of the missions of the anesthesia department with a focus on their clinical enterprise, which is very extensive, but also the training mission and the research mission. Commissioner Green, you had asked very astutely, you noticed that in the past there was a high rate for general anesthesia and supplemental sedation for our C-sections. And so how are we doing with this? And that was not included in the report. I am delighted to say that the rates have really dramatically improved. This was actually a resident QI project. And in fiscal year 18-19, before the resident project, the baseline rate was 13% for general anesthesia and 30% for supplemental sedation, for a 43% total rate. However, by fiscal year 2021, those rates had decreased such that the rate for general anesthesia was down to 8.3%. The rate for supplemental sedation was cut almost in half at 17%, for a total rate that went down from 43% to 25%. So they were really pleased that they were able to have that outcome. I will stop there and see if there are questions or comments for the informational part of the report.
Commissioners, are there any further comments? Commissioner Green, are you satisfied with those numbers?
I'm ecstatic with those numbers. They ought to take out a banner. That's really fantastic. And I mean, the residents, I hope that I know you guys are so wonderful in complimenting people for their good work, but that's really a remarkable achievement.
I will definitely pass that on to our anesthesia colleagues. I think they are really pleased with it. They presented that at PIPS in May.
Great, thank you.
Certainly. So then moving on for the items for potential action, So you will see that there is an update to the standardized procedure for the clinical pharmacist on the family medicine inpatient service. There were some minor updates, including a change of notation for how the providers will document in their own daily progress notes, and also some standardization of the language regarding initial proctoring and reappointment, so that that now aligns with the ambulatory care clinical pharmacist standardized procedure. And then Commissioner Green, I think you just had a sort of a general question about the clinical pharmacist duties on the family medicine inpatient service, you know, and the length of time that they would expect to spend on those. And so I reached out to the supervisor for our clinical pharmacists, and she checked in with the pharmacist who is doing this work. And in terms of the functions listed in item number 2, that really does encompass their whole 8-hour day pretty much. But in terms of how much time they spend on letter E specifically, counseling patients, that would be about an hour that's spent on an average day. Of course, there is some variability. So I'll see if there's any questions about that standardized procedure before I move on.
I don't, oh, Dr. Green.
Yeah, well, I just want to thank you for delving deeply into some of these questions. I think there was something later on in PIPS about, you know, patients leaving with a full understanding of the medications. And so I was curious to know, you know, that the pharmacists are so strong and actually so well trained, certainly better than certainly I am as a physician, that you know, I think it's a great resource to really improve that that particular metric.
We have a great love and appreciation for our clinical pharmacists. So so thank you for that.
Thank
you. Moving on then, in terms of the other items for potential action, there's a proposed addition to the standardized procedure for our inpatient nurse practitioners and physicians assistants in terms of being able to pronounce cardiac death for admitted patients. So we had a really robust discussion of this at the Credentials Committee. So this would pretty much uniformly be in the setting of patients who are DNR, DNI, do not attempt resuscitation, do not intubate, because with any other patient, the code team will be called. And there's a specific procedure in that case related to pronouncement and then documentation and writing a death note. So this would be when the nurse practitioner or physician's assistant is the primary person caring for that patient, and they're notified that someone has died. And we reviewed with their leadership that they are well-trained and receive an orientation on how to do this and to document it. Similar to how our residents do this in terms of the education they receive. So we were comfortable with that being added to their standardized procedure, and it will also be something that makes sense for their workflow. And then the last item for your consideration as an action item is that our Division of General Internal Medicine privilege list has a minor update that you saw in track changes. So there are some waived testing that is no longer done by DGIM, so that was removed. And then there was language added for contraceptive implant insertion and removal. And this is the same language that is being used by family medicine. So it was a standardized language that was added for people who apply for and are trained for that procedure. And that is what I have for the action list. Thanks for your attention.
Commissioners, the phone line still only has a staff member on there, so there's no public comment.
Oh, thank you. You went into the MP capability to pronounce death, and is it in your discussion that you mentioned that it would only be if they were called to do this? So it wouldn't be in the middle of care, and you're saying any death otherwise not on a do not resuscitate list would actually have a code call. So they would not be involved in that. I just wanted to be sure I heard that correctly.
Yeah, you heard that correctly. So they might well be part of the code team that might be called, but there would be a different procedure that would be gone through in that case, because the code team would decide when to call the code in the event of death. So the pronouncement would not be done by the nurse practitioner or physician's assistant in that case. And then just to be clear, in case it wasn't fully clear, this would not be for pronouncing brain death, which has a very particular set of requirements in terms of who performs it, and is a very specific skill. This would be for patients who experience cardiac death in the hospital.
Fine, no, thank you. Are there any other questions in regards to the request here for action? Is there a motion or motions to accept the recommended actions?
So moved.
I move to accept.
A second.
Thank you.
I will do a roll call vote. Commissioner Christian,
Yes.
Commissioner Green,
Yes.
and Commissioner Chow.
Yes.
The item's passed. Thank you, Dr. Winston. Item 10 is other business.
So commissioners, are there any other business that anybody would like to, present? Or Commissioner Christian, thank you for motioning, but I was not able to make sure that you were still with us here. I'm hoping that if you have any comments at this point in regards to the items that we have taken up, I know some of it could be quite technical, and we don't mean to do that. So if there's something that really is an area that you would like an understanding, a better understanding on, please take this opportunity to let us know.
Oh, thank you, Dr. Chow. It is quite technical, but I'm listening and learning, and you and Dr. Green take care of a lot of the technical questions and the in-depth matters that I could not possibly go into. But I also just do want to say that this is so much incredible work that everybody does every day, and I also appreciate how much work is spent, as Dr. Ehrlich was saying, preparing these materials and giving the presentations. And so please don't take my lack of questions for any lack of appreciation for the work that you're doing, or interest in it, or lack of interest in it. But I just wanted to say that as always, I'm so thankful for the work as a resident in the city, so thankful for the work that you all do. So thank you.
Thank you very much. And I think the extraordinary work in the presentations, Dr. Ehrlich, really has shown in these last several months, in which we're able to really clearly understand major topics, and really appreciate our opportunity to be able to continue to work with you all on this. Our next item is, I guess,
public comment. And there's no one on the public comment line, so we can move to a consideration for a closed session.
Okay, is there a motion for consideration of a closed session, please?
So moved.
Second.
Second, roll call vote, please.
Yes, Commissioner Christian,
Yes.
Commissioner Green,
Yes.
and Commissioner Chow.
Yes.
Great. All right. If you all could give me about 30 seconds, and anyone in the room who does not need to be or is not really appropriate to move into the closed session, we appreciate your attendance today and thanks for your participation. Okay, we are back into open session, and now a consideration of whether to disclose or not disclose. Discussions in closed session.
Motions in order, please.
Move not
I
to
move.
disclose.
Go ahead. Go ahead. Second.
Well, no. What did we move? I'm sorry.
Not to disclose.
We both moved not to disclose.
We moved quickly.
All right. I don't know who to ask first. I'll start with Dr. Chow since he wasn't part of that. Dr. Chow.
Yes.
Commissioner Christian.
Yes.
And Commissioner Green.
Yes.
Great. And finally, a consideration of adjournment.
Okay. Again, I think everyone has said to all of you that the Joint Commission reports are really outstanding, and I think in our mind they really help represent the work that you're all doing. So thank you very much for that. And I thought we were able to focus very nicely on some of the issues such as staffing and get a better understanding of all the things that we're going to be doing along with our other clinical challenges and where our scorecards are. So thank you again for the clarity that we are getting from our joint conference meetings here. So aside from that, if anybody wants to make additional comments, or we could accept a motion for adjournment.
Just to thank you on behalf of our team, Dr. Chow, for the very kind words. Really appreciate all of your support, especially during these very tough times. We really appreciate it quite a bit. Thank you.
Thank you. Okay, a motion for adjournment is in order.
So moved.
To adjourn. Second.
Roll call vote. Commissioner Christian.
Yes.
Commissioner Green.
Yes.
And Commissioner Chow.
Yes. Thank you, everybody.
Yes, thank you, and have a lovely day.
Okay.
Thank you.
Take care, everyone.